So common is back pain that most of us have had this unpleasant experience. It is the price we have to pay for walking erect, for sitting in our cars, and for taking all sorts of unsuitable exercise.
Fortunately, back pain need not be that serious. It is estimated that in 90% of all cases, back pain improves spontaneously without taking any therapeutic measures at all. Of the remaining 10%, many will improve on conservative treatment like simple bed rest and physiotherapy. A small percentage will need surgical intervention, for instance those who have a prolapsed disc or those who have instability at one specific level. We are here concerned with the remaining patients who have chronic back pain, who do not react to conservative measures and who are not candidates for surgery.
Roughly, we can discriminate between radicular and mechanical back pain. Mechanical back pain presumably emanates from one or more of the moving parts of the spine. These are the facetal joints posteriorly and the disc anteriorly. These structures have an interrelationship since they function together as a three-joint complex. Although one of them may be a predominant source of pain, they are commonly affected together, since abnormal function of one of the components will cause an abnormal load to the others. If the facetal joints are predominantly involved, we may consider a percutaneous facet denervation. How do we know these joints are involved? The patient with a so-called posterior compartment syndrome has predominantly back pain. There may be some radiation, usually to the hip region, or a little bit further down into the upper leg. But radiation into the lower leg is uncommon. Curiously, the pain is often worse at rest. On physical examination, flexion is usually unimpaired and painless. Extension, however, is painful. And there's circumscribed pain on pressure over the joints. Neurological investigations are invariably negative if the facetal joints are the only source of pain. The diagnosis has to be confirmed with the aid of prognostic blocking. This should always be done under fluoroscopy and with small volumes of local anesthetic solution, since so much depends on the result. A falsely negative block may deny the patient a potentially effective form of treatment. A falsely positive block will cause disappointment after the definitive treatment. Suppose now we have made a diagnosis of facetal joint pain and we want to do a facet denervation. Let's first have a look at the innervation of the joints. The posterior joints are innervated by the posterior primary ramus, which splits off the segmental nerve immediately after it exits from the foramen. The posterior ramus then splits into a medial and lateral branch. The lateral branch serves muscle and skin in a triangular area adjacent to the median line. The medial branch runs posteriorly in the groove, which is formed by the superior articular and transverse processes and then curves round the inferior aspect of the joint. This is not all, however. These nerve branches communicate with similar branches, serving the level up, but mostly below, creating a little network on the posterior aspect of the facetal joints. To interrupt the supplying nerves, we have to position a radiofrequency electrode in the groove. This has to be done at several levels. due to the existence of the communicating branches. For instance, if you want to denervate the L4-5 joint, the highest lesion should be made at the L3 transverse process. To perform a facet denervation, we need a radiofrequency lesion generator. Such a generator has 4 functions. First, the impedance should be measured to check for faults in the electrical circuit. Then there is the function of electrostimulation. This serves the function of physiological confirmation of the proper position before the radiofrequency lesion is actually made. Thirdly, there is the lesioning function indicating the output of radiofrequency current and including a time clock. And finally, there is the function of temperature monitoring. The temperature at the tip of the electrode can be measured with a thermistor or with a thermocouple. The more advanced type of monitoring is with a thermocouple, since these probes can be made of a very fine diameter. Therefore, they can be used in conjunction with small diameter cannulae. This enables the operator to introduce a cannula without prior administration of local anesthetic solution into the deeper layers. We can therefore make full use of electrostimulation. For the lumbar facet denervation, we use disposable 22-gauge SMK cannulae. They come in 6, 10, or 15 centimeter lengths. Usually the 10 centimeter variety is adequate for a facet denervation. These cannulae are Teflon covered except for a 5 millimeter active tip. When the stylet is removed, they accommodate the RF probe of corresponding length. Another thing you need is a good X-ray machine. We are using a Philips BV25, and we use it for the following reasons. First, the C-arm can be moved from one position to the other without effort. And if you do a lot of radiofrequency work, you'll realize how important this is. Then the image is of excellent quality. If it is used in the intermittent mode, several images are superimposed to one another, and this results in a final image which is of better quality than during direct imaging. This is useful since it limits exposure to X-rays to a minimum. Next, there is the possibility of storing up to 25 images. We have a matrix camera coupled to the BV25, and this enables us to document all procedures at the end of the session. This avoids unnecessary delay during the procedure. The importance of documentation goes without saying, if only to avoid legal implications. Another important item is the operating table. This should not contain radiopaque material, and it should not obstruct the movements of the C-arm. Preferably, it should be on wheels, so that the position of the patient is easily adjustable to the X-ray apparatus, rather than the other way around. It can be easily constructed by any technical hospital department, or else it is commercially available. We are now ready to start the procedure. First, we have to choose the proper X-ray projection. As you see here, the groove between the superior articular and transverse processes does not project well on a straight AP projection. If you use this projection, you may easily end up with a needle hitting the superior articular process itself. If we rotate the C-arm to a 10-degree angle with a sagittal plane, the groove itself becomes clearly visible. For the procedure at the L4-S1 level, the patient is positioned prone on the operating table with a pillow under the abdomen. The C-arm is positioned in a straight AP view first, then the angle of 10 degrees with the sagittal plane is taken. The optimal angle with the transverse plane is found by rotating the C-arm slightly back and forth until the groove is clearly seen on the screen. Insertion points are now marked directly overlying the groove. The proper length of the SMK probe is checked. The skin is disinfected and the area is draped. And the first cannula is introduced in the direction of the X-rays. If necessary, the direction is corrected while the cannula is still in the superficial layers. At this level, correction is easier and less painful to the patient. The tip of the cannula should be seen overlying a point just caudal to the groove in order to avoid passing the groove inadvertently. The cannula is now carefully further introduced until contact is made with bone. As soon as contact is made with the groove, the direction is changed slightly towards more lateral and superior until the tip is felt to just lose contact with bone. The first cannula is now in position. The other two cannulae are introduced in the same manner. For the lower cannula at the sacral border level, the angle with the sagittal plane may have to be decreased slightly if the iliac crest is very prominent. The position of the cannulae is now stored into the memory. The proper position should now always be checked on a transverse projection. The tips should be just posterior to the plane of the intervertebral foramina. Electrostimulation is now carried out at a frequency of 50 Hertz. The patient should feel a tingling sensation at a voltage not exceeding 1 volt. He is then asked to report where he feels the tingling. This should be in the back, not in the leg. If there's any doubt that the cannula is at a safe distance from the segmental nerve, motor stimulation at a frequency of 2 Hertz is carried out. This should cause no response in leg muscles at a voltage of at least 3 volts. One milliliter of 1% xylocaine is now injected through each cannula. While doing this, care should be taken that the cannula is securely fixed with the other hand to prevent displacement. A 60-second 80-degree lesion is now made in each consecutive cannula. And the transverse projection is stored in the memory.
In some of these patients, there is some doubt as to the existence of mild radicular pain on top of the facetal syndrome. In this case, you may want to combine the treatment with epidural administration of steroids. The aim of such an injection is to get a high concentration of steroid in the trouble area. The injected volume should therefore be small to prevent dilution, and if these small volumes are injected into the epidural space, you have to be sure that the needle ends up on the right side of the median line. There is therefore a good reason to do these injections under fluoroscopy.
We are using a Top X needle for this injection. This needle is Teflon covered, and it is originally designed for nerve block or plexus anesthesia with a facility of electrostimulation. The reason why we use it is its short bevel, which limits the risk of inadvertent puncture of the intradural space. Also, a Teflon-covered needle has very little resistance with the surrounding tissue, which makes it very easy to handle. The angle of the C-arm with a sagittal plane is decreased to 5 degrees. The L5-S1 interspace is now usually clearly visible, and a point directly overlying the space is selected. A syringe containing 0.5% of xylocaine is connected to the needle, and the needle is then introduced parallel to the X-rays. The proper direction is regularly checked on the screen while introducing the needle further. The tip should point to the proper side of the intervertebral space, but it should not point too far laterally to avoid puncture of the S1 root, which runs here on its way to the first sacral foramen. Some local anesthetic solution is injected from time to time, and once the needle is felt to enter the ligamentum flavum, a constant pressure is kept on the syringe. The needle is carefully advanced until the loss of resistance is felt. 0.2 to 0.3 milliliters of water-soluble contrast solution is now injected to confirm the proper spread of the fluid. If there is any doubt of the proper position in the epidural space, the spread of contrast is checked on a transverse projection. Finally, a mixture of 80 milligrams of Depomedrol and 2 milliliters of 0.5% xylocaine is injected.
The post-operative course after a facet innovation is usually eventless. There may be some local soreness for some days. An unusual complication is a small area of hyperesthesia which may result from injuring a cutaneous branch, presumably by making the lesion too far anterior. If this occurs, it always resolves without further treatment. Otherwise, this seems to be an uncomplicated procedure if the technique is strictly followed. What can we tell the patient to expect? The success rate is about 70% if the procedure is done on the right indication. Recurrence of pain occurs. If there is an early recurrence, this usually means that other mechanical structures were involved as well.
Specifically, the annulus fibrosus may play a role, confirming that we are in fact dealing with a three-joint complex. There are now new radiofrequency procedures for the treatment of this type of pain, but this is not today's subject.
If there is a late recurrence of pain, say after 1 year, there is the possibility of re-innovation, since the cell bodies have not been destroyed during a facet innovation. This, however, is not always the case, and the diagnosis of recurring pain is an entirely new ballgame. As in the lumbosacral area, pain emanating from the cervical spine can be either mechanical or radicular in nature. We are here concerned with mechanical pain, and in mechanical pain there is a difference between back and neck. Mechanical back pain may emanate either from the posterior joints or from structures in the anterior compartment, notably the annulus fibrosus. Paravertebral tenderness may be found in both conditions, and the diagnosis of facettal pain has to be made by physical examination and by prognostic blocking.
In the neck, however, it appears that in mechanical pain, the joints are nearly always responsible. Anterior mechanical pain occurs much less frequently. The joints are easily palpable just lateral to the long muscles of the neck, and if they are tender, we may safely assume that they are the cause of the pain. For this reason, a percutaneous facet denervation is more frequently indicated in the cervical area, and it also has a higher success rate. If facetal neck pain does not improve on conservative therapy, we can do a percutaneous facet denervation. Let us first have a look at the anatomy of the nerves in this area. The segmental nerves exit from the foramen in an anterolateral and caudal direction. After exiting, they remain in the same oblique plane for some distance. The posterior primary ramus, serving the facetal joints, branches off posteriorly and curves around the joint. If we want to interrupt the posterior primary ramus, we have to keep this anatomy in mind. In the cervical area, the transverse processes are too small to serve as a landmark during introduction of the electrode. The only way to make sure that the electrode does not come too close to the segmental nerve is to use an oblique X-ray projection in the plane of the exiting nerves. As long as the electrode tip is kept well away from the plane of the intervertebral foramina, the position is safe. This is easiest to monitor if the electrodes are introduced from slightly posterior. To perform a facet denervation, we need a radiofrequency lesion generator. Such a generator has 4 functions. First, the impedance should be measured to check for faults in the electrical circuit. Then there is the function of electrostimulation. This serves the function of physiological confirmation of the proper position before the radiofrequency lesion is actually made. Thirdly, there is the lesioning function indicating the output of radiofrequency current and including a time clock. And finally, there is the function of temperature monitoring. The temperature at the tip of the electrode can be measured with a thermistor or with a thermocouple. There are 2 different types of electrode systems that one can use in the cervical area. The short 6-centimeter version of the SMK system offers the advantage of temperature monitoring. However, the cannulae are introduced very close together, and it's difficult to keep the cannulae in position while taking the radiofrequency probe in and out during the procedure. An alternative is the SME electrode, which is 23 gauge with a 5mm active tip. This electrode has plastic tubing attached to the needle. Thus, handling the electrode is not necessary once it is in position. By trial and error, it has been found that if the voltage of the radiofrequency output is raised to 22 volts, a tip temperature of 80 to 90 degrees is obtained. Another thing you need is a good X-ray machine. We are using a Philips BV25, and we use it for the following reasons. First, the C-arm can be moved from one position to the other without effort. And if you do a lot of radiofrequency work, you'll realize how important this is. Then the image is of excellent quality. If it is used in the intermittent mode, several images are superimposed to one another, and this results in a final image which is of better quality than during direct imaging. This is useful since it limits exposure to X-rays to a minimum. Next, There is the possibility of storing up to 25 images. We have a matrix camera coupled to the BV-25, and this enables us to document all procedures at the end of the session. This avoids unnecessary delay during the procedure. The importance of documentation goes without saying, if only to avoid legal implications. Another important item is the operating table. This should not contain radiopaque material, and it should not obstruct the movements of the C-arm. Preferably, it should be on wheels, so that the position of the patient is easily adjustable to the X-ray apparatus, rather than the other way around. It can be easily constructed by any technical hospital department, or else it is commercially available. The first patient we would like to show you is a classic. This 82-year-old lady has had pain on the left side of the neck for over half a year now. The pain is constant, and it is worse at night. There's some radiation to the occipital area, but not to the shoulder. On examination, there's tenderness over the upper 2 or 3 facetal joints, and there is limitation of rotation to the right side. For the facet denervation, the patient is prone. The C-arm is maneuvered in an oblique position at an angle of about 20 degrees with a horizontal plane and about 15 degrees with a transverse plane. The object is to get a good view of the intervertebral foramina, and therefore these angles may vary slightly from patient to patient.
This is the oblique projection. This is where the 3rd cervical nerve comes out. The 4th cervical nerve runs here, the 5th here. Here there are arthritic joints. This one is affected, this one also. Now the tip of the electrode should be placed here, and here, and here. The introduction point is further posterior and caudal in such a way that this width is approximately doubled. In this spot we have an introduction point, and here.
Entry points are marked inferior and slightly caudal to the caudal part of the corresponding foramen. Just how much inferior the entry point should be depends on the angle of the X-ray projection and on the width of the neck. On an average, one may take double the width of the facetal column posterior to the foramen. The area is draped, but it is preferable to keep the face of the patient uncovered, since we have to communicate with her later on. The first electrode is now introduced in the transverse plane in a slightly cranial direction. The tip is kept in the superficial layers in order to check the proper direction first. It is then carefully further introduced, step by step, making sure each time that the tip is projected over the facetal column. Finally, contact is made with bone. The tip should then be at the level of the facetal joint space and a few millimeters posterior to the posterior border of the foramina. The other electrodes are introduced in the same manner. The most cranial foramen is the C2-3 foramen, accommodating the C3 segmental nerve. The posterior primary ramus, branching off from this nerve, serves the caudal part of the C2-C3 joint. To denervate the cranial part of this joint, it would be necessary to interrupt the posterior primary ramus C2. C2, however, has a very large posterior primary ramus, which is in fact the major occipital nerve, serving a large skin area. Since we do not want to damage such a large nerve, the upper electrode is positioned on the articular process of C2, just posterior to the C3 foramen. This lesion is supposed to interrupt a